Okay, good morning everyone. Today we'll be discussing the topic oral epithelial tumor. Today we'll be discussing part 1 for this topic. This topic has the following learning outcomes. At the end of the topic we should be able to list and describe the clinico-pathological aspects of benign epithelial tumors and human papilloma virus associated lesions of the oral mucosa. We should be able to define oral potentially malignant disorders and list out at least 10 such disorders. We should describe in detail the clinico-pathological aspects of erythroplakia and oral submucous fibrosis. We should describe in detail the etiology, molecular pathogenesis, clinical presentation and histopathological aspects of oral squamous cell carcinoma. We should identify and illustrate the histopathology of squamous papilloma, intradermal nevus, oral submucous fibrosis, well-differentiated squamous cell carcinoma, moderately differentiated squamous cell carcinoma, poorly differentiated squamous cell carcinoma, verrucous carcinoma, and malignant melanoma. We should be able to recognize the importance of early diagnosis in oral premalignancy and oral squamous cell carcinoma and apply the knowledge in thorough screening of high-risk patients. So in today's part 1, we would be discussing the clinico-pathological aspects of 5 benign epithelial lesions and human papilloma virus associated lesions. We would also be discussing about oral potentially malignant disorders. We would also be discussing about malignant melanoma. So before we start, let's make a brief introduction on the basics of epithelium. The oral mucosa, as we know, may be non-keratinized, parakeratinized, maybe non-keratinized or keratinized. The cells of the oral mucosa are roughly divided into keratinocytes and non-keratinocytes. Among the non-keratinocytes, melanocytes are a predominant cell type. The keratinocytes basically form the basal cell layer of the epithelium. These undergo cell division and migrate superficially migrate superficially until the topmost layer, and then they are exfoliated. Any pathology in these cells may result in a growth or an ulcerative growth. The growth may be slow growing and well defined, or it may be rapidly progressing and be painful. So these lesions are basically categorized under benign and malignant epithelial tumors. We will be discussing about the various benign and malignant tumors of the oral epithelium slowly throughout this session. First, let's begin with the benign epithelial lesions. A list of benign epithelial lesions are known to us. The most common among these are caused due to human papilloma virus. Human papilloma virus is a DNA virus out of which 16 subtypes have been isolated from oral lesions. The common benign epithelial lesions associated with human papilloma virus include squamous cell papilloma, verruca vulgaris, which is also known as common wart, condyloma acuminatum, and focal epithelial hyperplasia. Focal epithelial hyperplasia is also referred to as Hex disease. Before we further move into the individual lesions, I would like to describe in brief the pathogenesis of the life cycle of human papilloma virus. Once the virus infects the oral mucosa, it can be through direct contact or through secretions. Once it affects the oral mucosa, it invades into the deeper layers of the epithelium and it reaches the basal cell layer. Once it reaches the basal cell layer, it integrates itself to the basal cells, and the basal cell is now known to be infected. The virus undergoes replication within the basal cell layer, which results in formation of two daughter cells. The divided cells such formed are said to be virally affected or virally infected. These cells will further undergo maturation and migrate superficially, wherein it will be shed along with the exfoliated cells, hence making it infective. The exfoliated cells will also be infective in nature. Okay, to begin with squamous papilloma, it is a benign proliferation of stratified squamous epithelium. Two subtypes of human papillomavirus has been associated with squamous papilloma. These are subtypes 6 and subtypes 11. Knowing the subtypes is important because there are a lot of subtypes, and 6 and 11 are specifically associated with squamous papilloma. This lesion can affect any gender and it can occur in any part of the oral cavity. The lesion generally presents as a soft, painless, usually pedunculated growth. Clinically, it reveals finger-like projections, which have also been described as cauliflower-like or wart-like appearance. The projections may be pointed or blunt on palpation. Histopathological analysis of excised lesions of squamous cell papilloma will reveal stratified squamous epithelium arranged in finger-like projections. These finger-like projections entrap a thin vascular fibrovascular connective tissue core in between. A characteristic feature associated with squamous papilloma are the coilocytes. These coilocytes are virally infected cells and are generally seen in the superficial layers of the epithelium. These virally affected cells can be appreciated as large vacuolated cells with dark pycnotic nucleus. The treatment for squamous papilloma includes conservative surgical excision. Recurrences are rare. So this finishes the topic for squamous papilloma. This is an important topic and I suggest we revise this topic keeping in mind the viral subtypes associated with it, the clinical feature and the characteristic histopathological appearance. Moving on to the next topic, which is referred to as OPMDS or oral potential malignant disorders. These are lesions with a risk of malignancy being present within the lesion or condition either at the time of initial diagnosis or at a future date. The term oral potentially malignant disorders was given by WHO in the year 2005. Previously, various terminologies have been used, which include precancer, pre-malignancies, pre-neoplastic, pre-malignant lesions and conditions, cancer-prone, precursor lesion or epithelial precursors. But all these lesions have now been referred to as oral potentially malignant disorders. These OPMDs are significant because if properly taken care of, they may regress and heal, or if neglected, these may progress to malignancy. So, knowing about oral potentially malignant disorders can help significantly in reducing the incidences of oral cancer. The World Health Organization 2017 has a list of oral potentially malignant disorders. The most common and most significant of this is leukoplakia, which is a white lesion. Other lesions which have been characterized as oral potentially malignant disorders include erythroplakia, which is a red lesion, erythroleukoplakia, which is a mix of red and white lesion, a characteristic lesion associated with areca nut chewing, also known as oral submucous fibrosis, disc keratosis congenita, smokeless tobacco keratosis, palatal lesions associated with reverse smoking, chronic candidiasis, lichen planus, discoid lupus erythematosus, syphilitic glossitis, and actinic cheilitis. Oral submucous fibrosis is defined as an insidious chronic disease affecting any part of the oral cavity and sometimes the pharynx. Histologically, this lesion exhibits juxtaepithelial inflammatory changes and fibroelastic changes within the lamina propria. OSMF shows an increased prevalence in South Asia, particularly in India. The etiological factors associated with oral submucous fibrosis include areca nut, capsaicin from chilies, micronutrient deficiencies of iron, zinc, and essential vitamins. The lesion presents as a leathery texture and also reveals blanching of the oral mucosa. However, the most significant clinical symptom or chief complaint given by a patient includes progressive reduction in mouth opening. This can also be referred to as trismus. So coming to the pathogenesis of oral submucous fibrosis. OSMF is a collagen disorder where there is increased fibrosis within the lamina propria. The chief etiological factors, that is areca nut, on consumption will release compounds such as arecolin, tannins, and alkaloids. Arecolin results in increased fibroblastic proliferation, which results in increased collagen synthesis. Tannins cause the collagen fibrils to become resistant to collagenase. So overall, there is an increased collagen production and decreased collagen degradation within the connective tissue, resulting in the increased fibrosis. These features, which has been described in the pathogenesis, can also be appreciated under a microscope. An incisional biopsy performed for a patient with OSMF shows dense formation of collagen fibers within the connective tissue. These collagen fibers are present as thick bundles. It also shows a characteristic feature of juxtaepithelial hyalinization. Immediately below the basal cell layer, the connective tissue shows hyalinization. Because of this increased fibrosis, the overlying epithelium exhibits epithelial atrophy. There is a variable chronic inflammatory cell infiltration, which is predominantly of lymphocytes and plasma cells. Before we further progress into the next lesion, I would like to ask everyone few questions. These points are important and would help in identification of the lesion. So a case of oral submucous fibrosis, the patient typically presents with a chief complaint of progressive mouth opening. Intraoral examination of the patient will reveal dense fibrous palpable bands within the mucosa. Also, the patient will give a history of areca nut chewing. Visual examination of the oral mucosa will show blanching. The blanching may be restricted to the buccal mucosa, or it may involve other parts of the oral cavity, including the uvula and the soft palate. Incisional biopsy reveals dense collagen fibers, bundles of collagen fibers, as well as juxtaepithelial hyalinization. Oral submucous fibrosis is a potentially malignant oral disorder, and it has the potential to develop into oral squamous cell carcinoma. Early identification and progressive management of the lesion is necessary for developing a better prognosis. Moving on to the next lesion. that is melanoma, also referred to as malignant melanoma. It is a malignant tumor involving the melanocytes. As we discussed initially, melanocytes are cells of the oral epithelium. These are categorized as non-melanocytes. The melanocytes generally reside in the basal cell layer and are responsible for creating or producing melanin, which imparts color to the skin. Worldwide, melanoma is thought to form or to include the third most common cutaneous malignancy, with incidence ranging between 3 to 5%. Melanoma generally develops following exposure to UV radiation, shows a higher incidence in Caucasians. Geographically, the maximum number of cases of melanoma are encountered in the southern hemisphere and is seen in Australia and New Zealand. Increased prevalence are also seen in Northern America, Northern Europe, Western Europe, and Southern Europe. Other countries shows relatively less incidence of melanoma, including Asia. The lesion is commonly seen in sun-exposed areas, and the lesion may show variable presentation. They may present as pigmented plaques or show nodular lesions. Lesions may be preceded by melanoma in situ. Oral lesions are quite rare. In the oral lesions, male are more commonly affected. Common site of presentation includes the maxillary alveolar ridge and the hard palate. 70% lesions of oral melanoma affects the maxillary ridge. These lesions appear as dark brown to bluish black, slightly raised lesions. They may present as uneven lesions with nodular or papillary surface. The amount of melanin characterized in these lesions may be variable, with some areas appearing light, whereas others appearing dark brown or black. Melanomas are extensively invasive lesions, which makes the prognosis very poor. Melanoma is characterized by different growth phases. These growth phases may be either radial in nature or vertical. In the radial growth phase, the atypical melanocytes will migrate in an horizontal manner, whereas in a vertical growth phase, these atypical melanocytes shows infiltration into the underlying connective tissue. Based on the clinical appearance, the lesion has to be evaluated under 5 parameters to arrive or suspect a diagnosis of melanoma. This has been referred to as the ABCDE criteria. The ABCD criteria should be applied for any pigmented lesion in order to exclude or rule out melanoma, which shows poor prognosis. So, if we encounter a pigmented lesion, we should be evaluating under the following. A stands for asymmetry. We should observe the lesion by forming an imaginary midline and see whether each half is symmetrical or not. Melanomas generally are asymmetric in nature. So asymmetry can be an important clinical parameter for evaluation. Next, we should evaluate the border of the lesion. Benign pigmented lesions usually show a well-defined and regular border. Melanoma, on the other hand, has an ill-defined and uneven borders. The next criteria for evaluating a pigmented lesion is color. Benign asymptomatic lesions are generally pigmented, are generally showing a uniform hue throughout the lesion. Malignant lesions, on the other hand, shows uneven distribution of color throughout the lesion. Next parameter for evaluation would be the size of the lesion. Benign lesions are generally smaller than 6 mm in diameter. Malignant lesions, on the other hand, show size or dimension exceeding 6 mm. Finally, the most important aspect of evaluation of a melanoma is E, or evolution. Benign lesions are generally static in nature and do not progress. They have been present for a long time and has shown the same dimension throughout. Malignant lesions, on the other hand, shows a rapid progression in its clinical characteristics. The patient would generally complain that the lesion has been rapidly growing and has been showing variation in size, shape, and color. Incisional biopsy is necessary for such pigmented lesions. The lesions on histopathological evaluation reveal atypical melanocytes. These atypical melanocytes shows two morphological patterns. Either they appear as epithelioid or they may show spindle-shaped nature. The atypical melanocytes show various patterns like islands, nests, or clusters within the connective tissue. These atypical melanocytes have a large nucleus and prominent nucleoli. Special markers which can be used for melanoma or diagnosis of melanoma includes an immunohistochemistry marker, that is HMB45. These markers are used characteristically for staining of melanocytes and gives a positive staining as seen in the photomicrograph here. So this concludes the part 1 of today's topic. So today we discussed the basics of viral lesions of the oral cavity. We have to understand the importance of squamous cell papilloma, its association with human papilloma virus type 6 and 11, the pathogenesis of human papilloma virus in causation of such tumors is important. We should be able to identify the clinico-pathological aspects of squamous papilloma. We would be further discussing the same as part of our practical session wherein we will be discussing a case of papilloma. The histopathological aspects will be further dealt and discussed during the practical session. Oral potentially malignant disorders is an important topic and we need to know its definition, its importance. We need to know the names of at least 10 of these oral potentially malignant disorders, including leukoplakia, erythroplakia, and OSMF. We need to know that clinico-pathological correlation factors for OSMF, including the characteristic clinical features and the characteristic histopathological features. We should know the clinical characteristics of malignant melanoma, including the ABCDE criteria which helps in detection, and the histopathological features which will ultimately lead to the diagnostic confirmation of the same. Treatment for melanoma includes surgical excision or resection along with neck dissection. Since it is an aggressive lesion, it should be remembered that melanomas have a poor prognosis. Okay, moving on to the next topic, oral squamous cell carcinoma. Oral squamous cell carcinoma is an invasive epithelial neoplasm with varying degrees of differentiation and a propensity to early and extensive lymph node metastasis, occurring predominantly in alcohol and tobacco using adults in the 5th and 6th decade. OSCC includes 90% of all oral malignancies. What we refer to as oral cancer is not just oral squamous cell carcinoma, it includes other malignancies as well. However, oral squamous cell carcinoma forms a significant part of all the oral cancers. These lesions can occur in any part of the oral cavity. However, there will be clinical variations in relation to this cause or also in relation to the geographic location. The lesions present as varied forms in different parts of the world. In context of Malaysia, oral cancer is prevalent in the Indian ethnic females. However, overall, as you can see, men are more commonly affected than women. If we observe the ethnic distribution of this lesion, it can be seen that it predominantly affects the Indian population, with females showing the highest incidence. Oral squamous cell carcinoma of the oral cavity is commonly seen in the tongue in case of males and in the floor of the mouth in females. A variety of risk factors are associated with the development of oral squamous cell carcinoma. Hence, it is a multifactorial lesion. These include lifestyle, ionizing radiation, viruses, chronic infections, immunocompetency, and genetic factors. However, the most significant of the factors associated with oral squamous cell carcinoma are categorized under lifestyle factors. Tobacco smoking is one such lifestyle which is significantly associated with the development of oral cancer. Tobacco can be consumed in smoked form or smokeless forms. Whichever the form of use, both are associated with the development of cancer. The tobacco, when consumed in smoke forms in the form of cigarettes, BDs or pipes, are known to produce at least 50 known carcinogens. The most significant of these carcinogens are tobacco-specific nitrosamines, free radicals which cause an alteration in the antioxidant enzymes. The development of cancer displays a strong dose-response relationship in relation to the use of tobacco. So, a person who has a higher frequency and duration of smoking is at a higher risk of development of oral cancer as compared to a person who has a lower frequency and lower duration of use. It is important to understand here that a person who does not have the habit of smoking tobacco is at an even smaller risk of development of oral cancer. Hence, cessation from tobacco use is considered an important aspect of treating or managing cases of oral cancer. Tobacco, when consumed in the smokeless form, can be either chewed, plugged, or snuffed. Betel quid is an important habit of, or is a common habit of consuming tobacco in the chewed form. The betel cup basically includes a betel. The betel quid basically includes a composite mixture of various components along with tobacco, which is wrapped into a betel leaf, which is within a betel leaf and is called a betel quid, as you can see in this picture. So the betel quid includes areca nut, the leaf itself. Snake lime is added to this mixture. We'll have tobacco, catechu, spices and sweetness. Snake lime, when mixed with saliva, releases reactive oxygen species, which can result in tumor initiation. Also, nitrosation of the areca alkaloids, areca nut, specific nitrosamines, mutagenic and genotoxic properties of this will induce tumor. The snake lime also increases the susceptibility to other ingredients of betel quid. Alcohol is also known to be a possible carcinogen. Alcohol gives rise to the production of acetaldehyde, which is a suspected carcinogen. It is well known based on research that the habit of alcohol, when added along with smoking, multiplies the risk of development of oral cancer tremendously. The increased acetaldehyde burden within the body results in the activation of pro-carcinogens, which induce the cytochrome P450-2EI dependent microsomal biotransformation. This biochemical process makes the cells susceptible to undergo dysplasia. Further, there are different components or factors which are considered as possible risk factors for oral squamous cell carcinoma. The role of diet, even though minor, cannot be neglected. According to various epidemiological studies, diet plays some role in the development of carcinoma. People who have a high fruit or vegetable consumption have shown to have a protective effect of the oral mucosa. Diets rich in antioxidants also shows a protective effect. Diets deficient in iron, glutathione shows increased oxidative stress, which can be a precursor for development of carcinoma. Diets deficient in vitamin C, vitamin E, vitamin A and carotenoids also shows an increased risk of oral squamous cell carcinoma. In addition to diet, other factors are also involved in OSCC formation. Viruses, we have already discussed the role of human papilloma viruses in various benign epithelial lesions. The human papilloma viruses, certain strains of it are also discussed in relation to the development of oral squamous cell carcinoma. Epstein-Barr virus is another virus which is associated with malignancies like nasopharyngeal carcinoma and Burkitt's lymphoma. Oral health is also associated to some extent with the development of oral squamous cell carcinoma. When the oral health is neglected, it is seen that some people have the development of oral cancer. Oral cancer patients generally show poor oral hygiene and increased prevalence of periodontal diseases. The polymicrobial supragingival plaque can cause a mutagenic interaction with the saliva, resulting in the increased load of carcinogenic chemicals within the oral cavity. The body's immune system can also be related to the development of oral cancer. Undermined host defenses acts against the carcinogens. Genetic factors, immune factors, dietary factors Drugs can also result in undermining of host defenses. Acquired immunodeficiency syndrome is a significant viral disease which is known to impair the human's immune system and is known to give rise to development of certain malignancies. So at the end of this session, we should be able to remember that oral squamous cell carcinoma is a multifactorial disease caused by a variety of factors, with tobacco being the most significant one. The presence of various carcinogens within the tobacco, such as nitrosamines, need to be remembered. The various other risk factors associated with squamous cell carcinoma has also important and needs to be discussed. The role of betel quid along with areca nut is significant. The multiplicative risk of alcohol and tobacco is significant. Role of viruses as well, and role of diet. Pathogenesis of oral squamous cell carcinoma will be discussed in the next topic. I would suggest all the students to revise the topics discussed until now. Make a list of doubts related to any topic. Further discussion on the same will be carried out on the e-portal under the discussion board. Students are requested to key in their questions. Within a day, discussion will be continued for a week's time. Further histopathological discussion will be conducted during the practical session. Thank you.